Whenever you talk about anemia, now there are three groups of anemias. They pinpoint to how did the patient get anemia. So anemia, give me one word to a phrase to describe it, Stephanie. So when someone has anemia, what do they have, or what do they don't have? Okay, they don't have enough red blood cells. Now there's three ways to get low red blood cells. And what is the importance again of red blood cells? They transport oxygen. That's their only job. Transport oxygen. So you don't have enough red blood cells, so you don't have enough oxygen, basically. So is it important to have enough red blood cells? All right. So you can have the best working lungs in the world, but if you don't have any red blood cells or not enough red blood cells to deliver that oxygen to the rest of the body, they're useless, right? So there's three ways to get this. Either you have a problem with production, not producing enough, or you're destroying it too much, or you're losing it, right? So let's take it one at a time. So with production means it's either a problem. Where do we produce red blood cells? The bone marrow, with the help of what hormone was that from the kidneys? Erythropoietin, yeah? Okay. And there are triggers, therefore, yeah, to promote the production of red blood cells. So as far as production goes, it could be the raw material. Let's say, what do you need to produce it? You need certain minerals, yeah? So you need, yeah, iron, folic acid, vitamin B12, okay? So you need nutrients, basically, in order to make red blood cells. Or let's say, even if you're eating it, you're eating good enough foods with those nutrients, but the problem could be maybe you're not absorbing it. It could be a malabsorption problem. Or let's say if that's maybe you don't have resources for it. Let's say you live in a far out country away from water. So are you anywhere near sources of those nutrients with necessary for that? So it could be that, right? So there's different factors, but all leading to decreased production. Let's go to increased destruction. So now you have diseases like sickle cell disease, or let's say you have aplastic anemia. Okay, that's a form of cancer. And there's primary and secondary aplastic anemia, or maybe you're receiving chemotherapy, for instance. Okay, so that will destroy your cells, right? Or let's say a consequence of blood transfusion, say hemolytic anemia, okay? Hemolytic transfusion reaction. So that covers increased destruction. Or 3, you're losing the blood. There's acute and chronic blood loss. We just talked about one a while ago under bleeding, right? Okay. So again, it depends on the pathophysiology will depend on, well, what did you have? What do you have that's causing you to have low red blood cells? So that's what we investigate whenever someone comes in, blood count is low. Let's see. What is your problem? Is it production? Is it destruction? Or are you losing blood? So there's a table. It's kind of long, so it's just you missed that part, but we'll go to the table, okay? You'll catch up. So I mentioned about erythropoietin under production, and let's go to the table. So 29-1 gives you the 3 groups. So it's a production problem because of the deficiency of these, or it could be a failure to absorb these things. Okay, so what would cause you to not be able to absorb, let's say, what would cause you to have B12 deficiency? What surgery did you have? Gastrectomy, yeah? So that would cover also weight loss surgeries, because they either make your stomach smaller or through banding, or maybe they remove. Okay, they removed it because you had stomach cancer, for instance. Okay. Because how do you absorb B12 again? What do you need to absorb it? The initials are IF. No, IF, intrinsic factor. Remember that, Dr. Farrington? Okay. So intrinsic factor is necessary in order to absorb B12. So no stomach, no intrinsic factor, no B12. Okay, so that's why after weight loss surgery, for instance, what do these people take forever? Vitamin B12 injections. Yeah. Okay. And I already mentioned about cancer. So here's the loss. Okay, so it could be acute or chronic bleeding, GI tract, or wherever you're bleeding from. And then the increased destruction. So you got hemolytic types of anemia, or including sickle cell disease. Okay, sickle cell anemia, they're not destroying it, but they are sickling, which prevents them from carrying oxygen now. So since we have different causes, will the treatment be always the same? However, any person, regardless of the type of anemia, what will they all look like? The same, right? Same. They have similarities with a few exceptions. There will be some symptoms which are exclusively found in iron deficiency, exclusively found in B12 deficiency, but for the most part, they share the same manifestations. So it doesn't have to be difficult to answer anemic questions on the exam because they will share the same manifestation. So go back to what is the purpose of red blood cells? So they carry oxygen. So your management will also be similar, right? So there will be similarities in how you treat or take care of patients who have low red blood cell count, regardless of the cause. Of course, treatment will vary. However, since their manifestations are the same, they will also share the same needs, okay? Same requirements. So let's go now to the manifestations. So again, there are similarities, but there will be slightly differences that once you find exclusively in certain types of, especially the low red blood cell production type, which covers iron deficiency, B12, folate deficiency, anemia. Under production, decreased production. So with SCD, for instance, sickle cell disease, you still remember this? They discussed this in PEDS, yeah? This starts as a pediatric condition. Okay, so and this is genetic, yeah? Let's review quickly. So how do we treat sickle cell disease when they're admitted in the hospital? Are they admitted, by the way, because of sickle cell disease? Of sickle cell crisis. The crisis. So what triggered the crisis? So if you group them all together, what do they all fall under? What happened to the patient? Why did they go into a crisis? Oxygen levels dropped. Remember? Okay, let's go to SCD. You may have, because it's a frequent. So I'll come back to 911. Let's go to sickle cell quickly. So page 919. So you know this is genetic, yeah? And who are carriers and who are manifestors of the disease? Well, actually, either can manifest the disease. Anyway, so the patients have pain, yeah? So these patients' main complaint would be pain. Of course, they will also have shortness of breath because they have low red blood cell count. Okay, they didn't lose it, but they sickled, yeah, which makes the red blood cell useless. And as a result, they clump together and obstruct blood flow, causing ischemia in joints, in the abdomen, thus producing the pain. And here are multi-organ destruction that will result from chronic forms of the disease. So sickle cell disease patients, do they grow old? No, right? Because of these complications. They don't grow old. They don't reach retirement, right? At least the lifespan has improved. Okay, so now I've seen like 40, 50-year-old patients with sickle cell disease. Used to be these are teenagers. Okay, they die early, but now they're improving. So look at all the multi-system. Why though? Why did this result? Why result in multi-organ failure? Chronic ischemia because of the repeated attacks. So each attack causes ischemia to these organs, and then eventually they will fail one by one. This would be the worst. Yeah. The priapism. Okay. Would be the most life-threatening. Okay? Okay, so in crisis, the nature here is vaso-occlusive crisis, meaning blood flow is restricted because once the sickling cells happen, they clump and then obstruct circulation to joints, to the mesentery in the abdomen, causing extreme pain. And again, in all those organs we mentioned in the table earlier. So ischemia results. Only if they develop clots, yes. So system by system, so causes pulmonary hypertension, here acute chest syndrome. So these are the pains that patient will have. They could have strokes because of the, yeah, it doesn't have to be a clot, but because of the clumping, okay, so same effect. Reproductive disorders as they affect the ovaries and also just the libido, okay, so they now for management, since again, what are the triggers? Okay, any condition that will lower oxygen levels. So it could be any illness. So flu will drop your oxygen level, yeah? Pneumonia, okay? COVID, yeah. Okay. So if these patients, let's say, have asthma, yes, they will have frequent attacks or crisis episodes. As I mentioned, so they will, they're rarely exceeding 60. Okay, so they reach 40s and 50s now, better than decades ago. So there's promising treatment. There's still no cure. They are trying stem cell transplants, meaning replacing the patient's, what are stem cells again? So these are primitive, yeah, so primitive cells. So where is this going to be transplanted? Into the bone marrow. Okay, so if we replace the patient's bone marrow stem cells, then will they still produce those hemoglobin S molecules? Okay, no more, yeah? Okay. But the problem is the matching, okay? So for treatment, they can use hydroxyurea. Now, this is not a cure, all right? Let me just put it this way. So we use hydroxyurea. It's a chemo drug used for cancer. The purpose of the drug really is just to reduce the sickling episodes, just reduce the crises episodes. So let's say you go on a crisis every year, and maybe once or twice a year in the fall or during flu season. So this will cut it down. So maybe there will be some years you don't have to have a crisis, right? So here, so they experience fewer episodes. It doesn't cure the disease. And the more you avoid sickling episodes or crises, then the longer your life expectancy becomes. Let's go now to transfusion. So these patients, one of the reasons they don't live long are every time they go into a crisis, they usually require a transfusion. If the blood counts are so low, meaning the normal blood counts are so low that they require a transfusion. And in one of these transfusions, then they'll probably get some serious reaction from the transfusion, and then that's what will cause an early death. So like I said, transfusions are not without risk. So we have a whole long list of blood transfusion reactions, from a harmless febrile reaction to a really serious hemolytic or allergic or bacterial contamination reaction. Not to mention iron overload, okay, or the complications of massive transfusion reactions, acute hyperkalemia or acute hypocalcemia related to multiple blood transfusion reactions. So for supportive therapy, we give IV fluids, yeah, to increase circulation, and then so therefore, if fluids promote circulation, can this indirectly manage pain? Yes, but of course, can you expect the patient to just receive fluids? Okay, fluids will take care of it. Can you do that? No, they will ask for opioids. Okay, so give them opioids. Okay. And this is a prime example of patients. Remember when we had pain chapter last semester? And then we talked about believing people about their pain. And then we emphasize that this is subjective, yeah. So the only evidence you need is the patient's self-report. Okay. So are these patients, because they'll hear every year, almost every year, it may be more than once a year. So do you get to know these patients? Yeah, they live in the neighborhood, so most likely they'll come to the same hospital. Same thing, they'll ask for pain medication. And what happens again when people take opioids for a long time? They develop tolerance and they will ask for more and more. So what will likely be reaction by the nurse? Here we go again, yeah? So make sure you don't treat them like that. Okay, these people are legitimately in pain. Of course, the behavior can be like annoying, yeah? So they'll ask, but is it their fault that it's not time yet? No, all they know, their concern is they're in pain right now. Yeah, I'm sorry if I'm opioid tolerant now, okay, but I am in pain. So since we use multimodal approach, so there may be NSAID use, which again causes kidney damage. And these are the ulcers that result again from the vaso-occlusive crises. And what's the ethnicity again of sickle cell disease patients? Majority Blacks.
It responds to malaria? Does it respond? It's a mutation to the malaria disease.
Malaria? I'm not aware of that. Not aware.
Best mechanism of malaria, but the side effect is
Oh, okay. Didn't know that.
isn't it less black or tropical periods?
I'm not aware. We kind of got ahead there. So let's go to iron deficiency. And it'll be similar here when we go to B12 and others. There'll be similarities. Okay? Let's start with iron deficiency. What do you need in order to absorb iron? Vitamin C. Okay. So these are people with less. What foods are rich in iron?
Deep garlic.
Right. So the people at risk are, of course, the ones here, say, have a stomach problem, for instance, so they can't absorb the iron, or maybe they just have deficiency in the iron intake. So part of the interventions is sources of iron. Let's see here if we have foods. Anyway, so let's review. What have you learned in fundamentals and farm? How do you administer? Let's start with oral iron.
Always involve care.
Okay, so with a straw, yeah? So they don't stain their teeth, and then proper oral care. Okay? And make sure they have vitamin C with it, yeah? We can give this IV and IM. If you are giving it IM, what method? Yeah, Z-Track method, so that way you don't get nasty stains on the skin, which is bad for summer, yeah? For your for your bikinis, okay? You got iron stains in your butt. You got them iron stains? Right, foods. So it could be a select all on your NCLEX. So these are the foods you pick. Organ meats. What are organ meats? And then beans. Okay, so any beans, leafy greens. Somebody said that earlier. Molasses. Who eats molasses? Where do we get it? My diabetes boy. Thank you. So here's detailed instructions for oral iron. Empty stomach. 1 hour or 2 hours after meal. 1 hour before or 2 hours after meals. Now there are, of course, what's the complication of taking iron? Constipation, and what's the color of your stools? Black. Now for patients, because this is forever, yeah? You take this forever. Now constipation will be a problem. Now there are other forms of iron, so make sure the doctor and the patient are talking about the complication. If the patient develops constipation, then they can consider the polysaccharide form, iron polysaccharide, which is less known to cause constipation. Constipation is a real problem with iron supplements. So here's your teaching, chart 29-3. Again, empty stomach and GI distress, the uncomfortable side effects. Vitamin C again to increase absorption. Stool will be dark. So for constipation, increase fiber. I mentioned to the straw, yeah, or spoon at the back of the mouth to prevent staining of your teeth. All right, that should be it for for renal disease. Remember this from dialysis? Okay, because the end stage, yeah, people on dialysis. So what are given to them? EPO. Okay, so erythropoietin or epoetin alpha, yeah, injection. So that's given weekly, subcutaneous injections. Aplastic anemia is a form of cancer. There's a primary and a secondary form. So primary aplastic anemia is a bone marrow disease. So kind of like cancer. There is a secondary induced by chemicals, say benzene or other industrial chemicals, or some certain antibiotics as well. However, this is not only for anemia. This is basically pancytopenia, because the patient, when you have aplastic anemia, meaning you also have thrombocytopenia and neutropenia as well. So yeah, you have pancytopenia. Treatment is depending if it's primary or secondary. If it's primary, they may treat it with chemo and stem cell transplant. For secondary, depends. If the drug is necessary to be taken then for the patient, then we just treat the pancytopenia symptomatically by either blood transfusions or no red blood cells, platelets, or white blood cell transfusions, or you can do the growth stimulating factor. What are those three again? We talked about in cancer: the poietin alpha, oprelvicin, and filgrastim. Okay, so don't forget those three injections. All right, megaloblastic anemias, these are now the B12 and folate deficiencies. For folic acid deficiency, there's a
They call it.
pancytopenia.
Also mentioned about
Megalo, yeah. Collectively, if you have B12 or folic acid, they're known as megaloblastic anemias. Meaning they call it megaloblastic because the red blood cells are abnormally large in size. So this is B12. These are the risk factors. So vegan, or anyone who doesn't eat B12 sources of foods, which are high in meats and dairy products. Or those who had surgery, gastric surgery, either from weight loss or maybe for cancer or other stomach conditions. Again, intrinsic factor is necessary to absorb B12. Pernicious anemia is a genetic B12 deficiency, not necessarily related to surgeries of the stomach, but still the same. They don't have intrinsic factor, so we call them pernicious anemia. Just a terminology difference, but they are deficient in B12. No, after surgery, we call it B12 deficiency anemia. But if it's genetic, then it's pernicious anemia. Okay, there's one, let me see if there's a picture. No, never mind. So under B12, there's no picture, but just imagine. So patients with B12 deficiency, including pernicious anemia, they have this. It's not seen in any other type of anemia. They have a smooth, beefy red tongue. Our tongue is supposed to have these tiny little dots, right, on the surface. They don't. They have the tongue is shiny. It's very smooth, very red. That doesn't mean they're healthy. Okay? That just means that because of the chronic form of the disease, the tongue is deprived of oxygen flow. So they lose those tiny dots on the surface of the tongue, resulting in a very smooth surface. Okay, so that's one of the manifestations exclusively found in pernicious or B12 deficiency anemia patients. The what? And that's not exclusive. No. By the way, one of the complications of anemia is heart disease, because if there's chronic hypoxia to tissues, does that include the myocardium? Okay, so that can also lead to heart failure. It's not only seen in B12. Okay, so any chronic anemia patient, including sickle cell disease, they will have heart failure as a result.
Oh, anemia.
Chronic. For sources of B12 and folic acid, they're about the same. There should be same foods mentioned here. Still the same, the dark leafy vegetables and red meats, beans, and legumes also. Those are good sources of both folic acid and B12. Okay, last one will be, because the others will be similar. Have you talked about thalassemia? Okay, let's do it briefly, and then we'll end with polycythemia vera. So thalassemias, this is a unique group. So these are exclusively found in people living around the Mediterranean Sea. So this is genetic. So who are people living around the Mediterranean? So Greeks, who else? Yeah, Jewish, and who else around there? Yeah, Arabs. Okay, so those people around the Mediterranean. Okay, if you're not familiar, look at the world map and the countries living around the Mediterranean. Those are the people at risk for thalassemia. Now, this is genetic, right? So they naturally have this. Of course, not all people there have thalassemia. So this is a sad disease. When you have thalassemia, they lack an ability to synthesize hemoglobin. So forever, since birth, they will require, because there's no cure for this, so they will require periodic transfusions. Not every day, but throughout their life, when the blood counts go low, no choice, they'll receive transfusions. And of course, you know what will be the outcome there. So if they have thalassemia, frequent blood transfusions, okay, transfusion reaction. So one of those will either they'll contract a disease or die from one or more transfusion reactions. That's the long story short. Okay, that's the problem with thalassemias. So here are most of those people are Middle Eastern, Southeast Asian, that area there. Okay, last will be polycythemia. Thalassemia. That's basically it, yeah, because there's no cure. No, at least with sickle cell, you can prevent crisis, right? By giving, vaccinations or avoiding crowds. Pretty much, if they don't get sick, then they won't get a crisis. Nothing they can do. I mean, yeah, they have, kind of like that. But this one is present from birth though. But children with thalassemia, they typically don't have those problems until they get older. Right, the book did not really specify details on polycythemia, but let me just describe as best I can. So the problem here is, unlike other anemias, wherein, because you'll wonder, why is this anemia when it is polycythemia? They actually have larger than normal number of red blood cells, platelets, and white blood cells. So this is not a deficiency, unlike the others wherein we were worried about low blood counts, yeah? This one's strange. This one is high, but then it's classified under anemia. Why? The number actually doesn't mean they have more functional red blood cells, functional platelets, or functional white blood cells. They are large numbers, but immature. They therefore are useless, basically. They're in the bloodstream, not helping, not performing their normal function, but instead taking up space. And when things that are not functional take up space in a narrow area, what will they cause? Clotting is the #1 problem with polycythemia. So you have the increased number of red blood cells. Not only that, platelets and white blood cells are also high here. So the manifestations will, of course, what will this do to your blood volume overall? It will increase. So blood pressure will, and what's the consequence again? You have too many cells, clotting. So hypertension and clotting will be, frequent clotting will be a problem here. So what will, now, and I know this is under secondary, but the management would be similar, okay? So just disregard, so polycythemia is not, this one is polycythemia vera. Okay, that's what I described, meaning these patients have a bone marrow problem wherein their bone marrow increases the production of red blood cells. So that's kind of like cancer, correct? Okay, so we do treat this like cancer. We treat it with chemo. However, oral chemo is used, not IV anymore. Okay, they changed the guidelines. Yeah, they use methotrexate, and hydroxyurea also is used. Now, polycythemia, the secondary form, you remember COPD? Or people with chronic hypoxic problems? Now, part of the compensatory is what will the body do when they have chronically low oxygen levels? They'll increase the red blood cell production. So this is that type of polycythemia, okay? Now, for the management, if the patient has polycythemia vera, you know, the one we discussed before, you know, when they have increased red blood cells, increased platelets, and increased white blood cells. So the #1 treatment, which is cheapest, is therapeutic phlebotomy. Yeah. By the way, so the blood is thicker, yeah, because of the, so what are the two major manifestations again? Hypertension and clotting, okay. So the cheapest way to treat it is they'll come periodically every few months because their hematocrit is like above 60%, like 58% and higher. So that's a very thick blood, right? So we remove blood. So just like they're going for a blood donation, okay? But of course, this is, can we give this to somebody? It's useless, basically. So we take it out, throw it, okay? Or give it to Filipinos. We'll make a nice soup with it, okay? That's good. I make them. High in iron. High protein. So therapeutic phlebotomy will be done about 3 times a week, every other day, not daily. So until the hematocrit level is normal. So as soon as hematocrit reaches 50%, we stop. Okay? So we remove blood daily. No, sorry, once a day, every other day until the hematocrit level is normal. Then they go home. That's all we can do basically. As far as the clotting, they really don't put them on anticoagulants. So patients I see usually receive aspirin. That's it, just to prevent platelet clumping. So they don't advise anticoagulation really for these patients. Okay, just aspirin. And the oral chemo, again, either methotrexate or hydroxyurea. Yeah. No, just in fact, very hypertensive.